Hi, everyone. Welcome. Thank you so much for joining us. This is a recorded presentation. My name is Rupinder Brar. I'm a addiction medicine physician. I work at St. Paul's Hospital. I also work in the downtown east side as a primary care provider and an addiction medicine provider. And I'm going to be presenting for you today take-home dosing for our new and updated clinical management of opiate use disorder guideline, which was just released this week. So we're very excited about that. And one of the main and key changes is the changes to the criteria for take-home dosing, also known as carries. So just moving on. Whoops. So first and foremost, I'd like to state that we respectfully acknowledge that the land on which the BCCSU and the land on which I live and work is the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. We recognize that the ongoing criminalization, institutionalization, and discrimination against people who use drugs disproportionately harms Indigenous people, and that continuous efforts are needed to dismantle colonial systems of oppression. We see our work connected to these efforts and hope that our work contributes to an addiction system of care that provides safe, respectful, and evidence-based care. So, the guideline for clinical management of opiate use disorder was first released in 2017, and we have since then released an update. So we're very excited about that. And as I mentioned earlier, the key objectives of this presentation is to review the take-home dosing of buprenorphine, naloxone, methadone, and slow-release oral morphine. So our OAT options. Excuse me. So we'll review the take-home dosing criteria. I'll review with you the dosing decision table, which sort of highlights key timeframes, and we'll do some case studies to provide context to all of this criteria to sort of bring the message home. So our key updates, let's start with buprenorphine naloxone. In 2017, the guideline highlighted that we want to allow people to provide people with carries of buprenorphine naloxone when they're clinically stable. We often provided 1 to 2 weeks of medication, and we were more restricted when it came to people experiencing homelessness or ongoing severe substance use. I know many of us still prescribe carries of buprenorphine naloxone, but the guideline really was a bit more restrictive. Now in 2023, we really want to ensure that people are considered for take-home dosing right at initiation of buprenorphine naloxone, and to really still consider safe storage of this medication, but people experiencing homelessness and ongoing substance use may still be prescribed take-home doses to really help improve retention and ease for our patients. Some of the more significant changes come with methadone and sustained release oral morphine. So I'll start with methadone. In 2017, our guidelines said we need urine drug tests for 12 weeks, so at least one test every month for 3 months. The person needed to be on a stable dose for at least 4 weeks. There need to be social, cognitive, and emotional stability. They needed safe medication storage, and we had to ensure that the urine drug tests showed no use of any other unprescribed substances, and that there was no signs of injection drug use and follow-up. So that was sort of key to how we've practiced with methadone up until now. Now our guideline states that we want to have appropriate urine drug tests that show that there's OAT adherence. We no longer require that patients have negative urines for other substances of use, but I'm going to get into details about that so it becomes a bit more clear. Now we want people to be on methadone for a minimum of 4 weeks. They don't have to be on a stable dose for a minimum, but they have to be on medication for about a month. We want to ensure clinical and psychosocial stability. Again, I'll get into some more details about what that will look like. And we definitely want to ensure that there's safe storage. Additionally, people experiencing homelessness, and other concerns, we really want to ensure we make sort of a case-by-case decision with the patient in mind. So I'll get into that a bit more. So for slow-release oral morphine, 2017, it was quite restrictive. So we only allowed take-home doses in exceptional circumstances. And really, people were required to do daily witness ingestion, irregardless of where they were at. And that was a significant barrier to treatment for people. And we heard that a lot from our patients. Now in 2023, we're saying that we're aligning slow-release oral morphine with methadone. So we want appropriate urine drug tests to show that they're taking slow-release oral morphine. We don't need the urine drug test to show abstinence of any other substance, they can still be using other substances. Again, I'll get into that. We want to make sure they're on slow release oral morphine for at least 4 weeks. It doesn't have to be a stable dose. It just has to be that they're taking that medication and tolerating it. Clinical and psychosocial stability, and safe medication storage. Again, I will get into some of that criteria. As I said, now let's review in detail some of those things to help better clarify how we can prescribe take-home doses. So some general considerations. We know that take-home dosing will increase motivation to participate in opiate agonist therapy, improve treatment retention, increase quality of life, and reduce barriers to treatment. One thing we've heard time and time again from people with lived and living experience is how challenging it is to get to a pharmacy every single day. We know the retention in BC has been on the decline for many, many years, and this is one key reason why. And so we can really try and do our best to support people with quicker carries or take-home doses to try and reduce some of these barriers. We also want to consider weighing benefits against personal and public safety considerations. So we want to make sure that we are really considering these pros and cons, and we'll get into that a bit more. We also want to consider early and flexible take-home doses in rural and remote contexts. I know I don't work in a rural place, but a lot of my colleagues in rural and remote contexts have been long having to make these early considerations, but now you have a guideline to help support all the great work you've been doing up to date. And we definitely want to provide information on the risks of combining opioid agonist therapy and other CNS depressants. So things like alcohol, benzodiazepines, any other CNS depressants that might present as a risk to folks who are taking opioid agonist therapy. So just the real basic safety things that we've always been doing, but having a different consideration for take-home dosing. So let's get into this. Buprenorphine naloxone. What does clinical and psychosocial stability look like? People are able to attend appointments. There's absence of unstable psychiatric comorbidities. So really psychosis, suicidality. So really focusing on the unstable piece. People can have schizophrenia and be stable on medication and be doing well. We're really talking about people that are experiencing some degree of instability. That there's an absence of severe behavioral issues in the clinic, absence of severe sedation, absence of high risk or uncontrolled substance use patterns that cause frequent overdoses or blackouts. So really the key here is that we talked about that urine drug test. Before, we had to ensure that the urine drug test was negative for other substances of use. Now, if there's some fentanyl in the urine or people have amphetamines, but they're not having frequent overdoses, blackouts, or their use isn't high risk, we can still consider take-home doses for folks who use a point a day. Some folks use more than a point a day, but still are able to have use in a way that isn't uncontrolled. Another key point is ability to safely store medication. Access to a secure lockbox or cabinet are key things that I think are important, since these are opioid medications and we want to ensure that they are safely stored. But the key piece, especially with our changes with this guideline, is point of care assessment is person specific. So I really want to highlight that piece, that we want to prioritize collaborative decision making. We have a guideline, a good one, to help support our work, but it is a guidance tool. We really want to ensure that in a case-by-case basis, we can make decisions that help benefit the patient. Consider alignment with the individual's treatment goals and base decisions on their changing needs and circumstances. So take-home dosing criteria, just to summarize, consider immediately for all people who meet the criteria. Again, we talked a bit about clinical and psychosocial stability, ability to safely store medication. We want to consider take-home dosing for people that are experiencing homelessness to better support them. People who continue to use substances can be considered for take-home dosing as well. So it doesn't have to be a negative UDT, as I mentioned before. So a quick transition to take-home dosing can help improve treatment retention and adherence. That is what we've been hearing for many, many years. So it's nice to be able to better support people with a guideline that also says, okay, let's help you with medication that you can take home, but still ensure safety. And that's what we're hoping to highlight today. So let's get into some of the bit more stickier pieces. So methadone and sustained release oral morphine. So let's start off by saying that the criteria are the same. So I'm going to talk about both of them together. So some considerations: people who continue to use non-prescribed substances can be considered for take-home doses. One big key change for us now. Take-home, right, sorry, I think there's an arrow that goes down. So next point. Take-home methadone and sustained-release oral morphine doses should start as individual non-consecutive doses for people who meet the criteria. So, we wouldn't start with consecutive days. So you start with maybe 1 or 2 doses to take home. It would be maybe a Monday. And if you transition, it'd be a Monday, Wednesday, Friday. So non-consecutive days. Then, of course, additional take-home doses can be offered gradually to those who consistently manage previous take-home doses, sustain medication adherence, and they are experiencing improved clinical and psychosocial stability. So that's a key point there as well. And once they do, we want to gradually progress them from 1 to 3 non-consecutive doses to 4 to 6 consecutive doses. So a weekly carry, for example. And you can do that in a time frame of maybe every 2 weeks. That would be an example. If someone's on 2 take-home doses, non-consecutive, you see them in 2 weeks, you reassess them, and they're doing better. You increase the amount of take-home doses, and eventually, once they're past 3 take-home doses, they're up to 4 to 6. It can be non-consecutive at that point. And again, we just want to ensure that people are doing better because of the take-home doses. You're able to sort of document and note some clinical and psychosocial stability. And of course, when you get into the cases at the end of this presentation, we'll be able to give a bit of context to that. Okay, so let's get into some of the criteria. So who would not be a candidate? Firstly, the new guideline, as we know, is less restrictive criteria for take-home dosing for full agonist medication. So we're going to now get into the full agonist, as I mentioned earlier, a bit more stickier than the buprenorphine naloxone for obvious reasons. But we do want to allow people gradual carries at 4 weeks is the key here. So once they've been on that medication, we want to gradually increase it. So let's get into the criteria a bit. So the yellow arrow, who is not a candidate? So inability to safely store medication, psychiatric illness, or other acute health crises. We talked about the psychiatric illness criteria of acute psychosis or suicidality, or maybe they have decompensated liver failure or other things with maybe some delirium that you're quite concerned about. Severe pneumonia causing significant issues that you may want to reconsider. But for the most part, we want to try and best support people to get their medication. Frequent missed doses and appointments would be not a candidate, and high risk or uncontrolled use patterns. So frequent drug poisonings, frequent blackouts. We know the drug supply is quite tainted and people can sometimes miss significant periods of time. And so not to be punitive with their medication based on that, but really to make a decision with your patient on what would make them a candidate. So once they've been on their medication for 4 weeks, you started somebody on methadone or SROM, for example, you can start the 1 to 3. Let me just change that arrow. We're on the second block. There's a yellow arrow. You can start them on 1 to 3 non-consecutive take-home doses. So again, it's been 4 weeks. They can store their medication. You've confirmed that they've been taking their medication for these 4 weeks. So they're not having a lot of missed doses. And then you have clinical and psychosocial stability. We'll get into that psychosocial stability again. And then you've done that, and then gradually over time, you can get to 4 to 6 consecutive take-home doses. So here they've been on these 2 medications, one or the other, for a minimum of 12 weeks when you're going to really do the consecutive days to take home. They have consistent medication adherence and improved clinical and psychosocial stability. Okay, so what does, let me just move on here. What does improved clinical and psychosocial stability look like? For the 1 to 3 non-consecutive take-home doses, when you start off, they can keep their appointments. There's no acute behavioral or psychiatric issues at the point of assessment. There's no high risk or uncontrolled patterns of substance use. So again, frequent drug poisonings, blackouts, or severe safety risks. Apologies for being a bit repetitive, but we really want to draw home these key points through this presentation. So that's what clinical and psychosocial stability looks like. So for those that we're going to, after 12 weeks of having some take-home doses, we want to progress them to have 4 to 6. So like a weekly carry, for example. Here, people having rare missed appointments, minimal unprescribed substance use. So this for me is so key. I have so many patients who chip away. They still use a bit of fentanyl a few times a week, so their urine is always positive for fentanyl, but they're doing well. So to read from the slide, it says, in alignment with the treatment plan and goals, with no recent drug poisonings or blackouts. So really, we know these folks who are still chipping away for various reasons. History of trauma, their current living circumstances. Maybe they've had an upsetting thing happen in life, and they're chipping away a bit, but they're still doing well enough to be able to safely take, store, and use their medication. So that for me is such a key change in this guideline. Excuse me. And then moving on to another key change, are urine drug testing for take-home dosing. So the guideline includes updates in urine drug testing for individuals on OAT, including those who have prescribed take-home doses. So really review that section. It's really well written. What we want to ensure that urine drug testing is now done when it really would impact the treatment plan. So we don't want to use it punitively or when results won't impact treatment. We've heard time and time again that having to provide a urine feels quite demeaning for our patients. We really don't need the urine as much as we used to need it, and we'll get into why. So firstly, there's no minimum number of required tests anymore for those on take-home doses. In the old guideline, it was between buprenorphine, naloxone, and methadone and SROM, you needed 4 to 8 random urine tests. We no longer require any random testing. You don't have to call your patient and say, you need to get here in 48 hours and provide a urine. We don't need to do random urine drug tests anymore. And there's no minimum number. Based on your practice, you can do a urine drug test when necessary, when you feel like it may impact your treatment plan. As a prescriber in the last 10 years, I will likely still do some urine drug tests in terms of treatment adherence, but there is no minimum number. And of course, a negative UDT for other substances is not required. So if a patient's still screening positive for cocaine, amphetamine, some fentanyl, but they're otherwise doing well, that is not grounds for us to stop their take-home dosing anymore. So key change there. So lots of positive changes to the urine drug testing that I think will alleviate some of the pressures, both on the prescribers, but also our clients, also on our patients. So let's get into some case studies to help give some context to all of this material we reviewed. So case study number 1. We have a 35-year-old male with a 10-year history of opiate use disorder. In his past history, he has experienced drug poisonings. Currently, he's on 120 milligrams of methadone for the last few months. He has ongoing fentanyl use when he misses doses at the pharmacy. So he uses about 2 points a day when he can't get to the pharmacy. He does have a diagnosis of schizophrenia. He's well supported by a mental health team, and he has stable housing. And he has no acute psychiatric issues at this time. So you start him on 1 take-home dose per week. After 2 weeks, you reassess him. He's doing quite well. And you transition him to 3 non-consecutive take-home doses. So he was picking up every Monday. He would take his dose in the pharmacy and then get the Tuesday dose on Monday and then go back to the pharmacy from Wednesday to Monday again. Now, after 2 weeks, you've reassessed him, and he's going to actually pick up doses Monday, Wednesday, Friday for the following day. So he has 3 non-consecutive take-home doses per week. You reassess him 2 weeks later after that. There's some concerns about worsening mental health. He describes not always taking his medication. He reports that medications are causing him some drowsiness. He's always felt a bit lethargic on them. He doesn't always want to take them. And you review his mental health with his mental health team, and you increase the frequency of assessments to once a week. You don't change his take-home doses at this time. He's getting 3 non-consecutive because he's managing those well, but you are a bit concerned that there's a bit of a change in his mental health. So what you do different here is you're going to increase the frequency of assessments to see him more frequently, and he also agrees that that would be fine. So a week later, you see this patient, and they have had a short destabilization of their mental health. So during this time that you see him, you do transition him back to daily witnessed ingestion after confirming that he was taking all of his carried doses. And it's a short destabilization. You're working with the mental health team, and he does do better, and he's much improved, and you continue his take-home doses at this time. Now you agree, because he's doing quite well, he's back to his 3 non-consecutive take-home doses, to do twice monthly assessments instead of monthly. And eventually, after doing a few of those assessments, he's doing quite well. You transition him to further carry. So he goes from 3 non-consecutive to 4 consecutive to weekly take-home doses, which he manages quite well. And I think in this case, we want to highlight that many people with other comorbidities or concurrent disorders really greatly benefit from carries or take-home doses if the circumstances allow it. So this person was using a lot when they would miss their pharmacy. And now we've sort of eliminated that because they have medication that they can store safely at home and not have to miss their doses at the pharmacy. And despite a short destabilization in their mental health, you were able to increase frequency of assessment, safely ensure a time when you could reinstate the carries or take-home doses. And really the key is to work with the patient, and that there's no real hard and fast restrictive criteria. It really depends on a case-by-case basis. Okay, case number 2. So we have a 52-year-old female living in northern BC, a 20-year history of opiate use disorder. They have daily ongoing fentanyl use. They've had 5 drug poisonings in 6 months. They're on and off their sustained release oral morphine and methadone for years. So they've tried both, but they're on and off. And because of the frequent missed doses, they have frequent restarts. They have a rural residence. The pharmacy is 30-minute drive from their home. When they're on oat and getting it, they're using less than a point a day, but when they're off oat, they're using over a gram a day. So the harms of being off oat are quite significant. We know that from lots of good rigorous data that off of oat, people use significantly more and the risk of death is significantly higher. So for this person, you see them, you restart them on SROM, the sustained release oral morphine, and you titrate them up to 1,500 milligrams. They're getting witness doses. You reassess them 4 weeks later. It's a virtual reassessment, and they're reporting some missed doses. They feel the dose of SROM is good, but when they can't get to the pharmacy, they get withdrawal, and they use about 1 to 2 points when they miss a dose. They haven't had any drug poisonings, and they're tolerating this dose well. They are able to safely store their medications. And so after this discussion, you start them on take-home doses 3 times per week. So it's non-consecutive. They're witnessing Sunday, Monday, Wednesday, and Friday. And you review the risks of take-home doses and ensure that it's a safe plan to have with them. And then you reassess them in person 8 weeks later. They're doing well. Their urine drug test is positive for fentanyl, morphine, and amphetamines because they still report sporadic ongoing fentanyl use. They find that the take-home doses have really improved their quality of life and their mood has improved. And so those are all reasons to document about their stability. Now, you reassess them 4 weeks later after all of their take-home doses that they're getting non-consecutively, and you continue them on their SROM dose because that's the dose they feel is working well for them. But now you're increasing their take-home doses to witness only once weekly. So they only have to drive that to that 30-minute pharmacy once a week. And you see them monthly now with virtual visits every other month. Now, why have we increase their carries further is because if you notice in the previous discussion, when they can't get to the pharmacy, they're still using. And so we really want to ensure that we're able to help try and decrease the unregulated use and their safety and provide ease, because they do describe lots of clinical stability. They state that they're a lot happier, their mood's improved, and their quality of life is improved. And so now this person is on weekly carries. You'll see them once a month virtually and or in person, and you'll continue to assess how well they're doing. And of course, the key point here is in rural, remote areas, it's obviously a lot more challenging to go get daily witnessed ingestions. And so it's important to consider earlier carries or take-home doses on a case-by-case basis. And that definitely is something that we would support as our key point here being outweighing pros and cons and ensuring safety, but the key point being that we better support our patients to be able to take medication that is quite clearly life-saving and important for them to try and decrease or eliminate use from the unregulated supply. Now, thank you for listening to this presentation. I hope it helped clarify some of the questions around take-home doses. Please reach out to us at the BC Centre on Substance Use if you have further questions. We have other resources that are available on the website, and here's the link to other great resources. That urine drug testing breakout resources are a really great one to read if you haven't yet. We have opioid agonist treatment medication summaries. We have a clinical guideline summary. Sorry, I'm reading these bullet points backwards. I'm not quite sure why. And of course, our new and improved clinical guideline. Always know that our 24/7 addiction medicine support line is available to you. You can call it any time of the day, any time of the year to ask any questions. And we have trained physicians on that line. And this is a line for physicians, nurse practitioners, nurses, midwives, pharmacists who are providing addiction and substance use care. So thank you again for your time. And please reach out if you have any other questions or concerns. Thanks very much.